Michael J. Campbell, MD. Virginia Mason Medical Center, Seattle, Washington. Case presentation. HPI, ISH is a 9-month-old healthy boy with 12 hours of worsening, intermittent abdominal pain. Colicky episodes lasting 5 minutes with 30-minute periods of sleep intervening. Increasing frequent. Mum noted him assuming the fetal position during the attacks. 1 episode of non-bilious vomiting. 1 episode of non-bloody diarrhea. No preceding viral illnesses P.A.F. Low-grade tachycardia to 160s, but otherwise stable. Gen. Comfortable, and sleeping abdomen, soft, more distended. Mildly tender with a questionable soft mass in the RLQ. Labs, WCT of 17.1 with 17% bands. Case presentation. Case presentation. Case presentation. Taken to the fluoroscopy suite where pneumatic decompression was attempted. Resolution of the evident intussusception, but not able to pass air or contrast into the small bowel. Subsequently, watched on the floor and returned for a plain film and US 4 hours later which showed no evidence of intussusception. Started on a diet and D/C the next day. Case presentation. Case presentation. Background. Intussusception refers to the invagination of a part of the intestine into itself. It is the most common abdominal emergency in early childhood. Epidemiology. Intussusception is the most common cause of intestinal obstruction in infants between 6 and 36 months of age. Approximately 60% of children are younger than 1 year old, and 80% are younger than 2. Male predominance, with a male-female ratio of approximately 3:2. Swiss study looking at cases of intussusception over a 3-year period. Intussusception is unusual in adults. Pediatrics. 2007 September, 123, 473-80. Pathophysiology. Intussusception occurs most often near the ileocecal junction. Approximately 75% of cases of intussusception in children are considered to be idiopathic. The intussusceptum, a proximal segment of bowel, telescopes into the intussuscipiens, a distal segment, dragging the associated mesentery with it. This leads to the development of venous and lymphatic congestion with resulting intestinal edema, which can ultimately lead to ischemia, perforation, and peritonitis. In the majority of cases in adults, a pathologic cause is identified. Study of 13 adults with intus out of Turkey over 7 years. 10 had intus of the small intestine. A pathologic cause was found in 12, 92%, with 42% representing malignant processes. Pathophysiology. In the majority of cases in adults, a pathologic cause is identified. In children, pathologic lead points include Meckel's diverticulum, polyps, lymphoma, HSP. It is estimated that 75% of childhood cases of intussusception are idiopathic in nature, with 25% having a pathological lead point. Meckel's, polyps, small bowel lymphoma, Hennixgon in purpura, a small bowel wall hematoma, account for a greater proportion of cases of intussusception in children younger than 3 months or older than 5 years. Pathophysiology. Taiwanese study looked at throat cultures in kids with intussusception and found an association with adenovirus versus control. The incidence of intussusception has a seasonal variation, with peaks coinciding with seasonal viral gastroenteritis. Intussusception has been associated with some forms of rotavaccine. Approx 30% of patients experience viral illness prior to intussusception. Viral infections can stimulate lymphatic tissue in the intestinal tract, resulting in hypertrophy of pale patches of terminal ileum acting as a lead point for ileocolic intussusception. Pathophysiology. Small bowel intussusception, usually jejunal or ileo-ileal, has been described in the postoperative period. The intussusception is thought to be caused by uncoordinated peristaltic activity and/or traction from sutures or devices. Clinical manifestations. Classic triad. Colicky abdominal pain. Palpable sausage-shaped abdominal mass. current jelly stool. Patients with intussusception typically develop the sudden onset of intermittent, severe, crampy, progressive abdominal pain, accompanied by inconsolable crying and drawing up of the legs toward the abdomen. The episodes usually occur at 15 to 20-minute intervals. Vomiting may follow episodes of abdominal pain. Between the painful episodes, the child may behave relatively normal and be free of pain. A sausage-shaped abdominal mass may be felt in the right side of the abdomen. Up to 70% of cases, the stool contains gross or occult blood. The classically described triad of pain, a palpable sausage-shaped abdominal mass, and current jelly stool is seen in less than 15% of patients at the time of presentation. Diagnosis: abdominal plain film. Features consistent with intussusception include signs of intestinal obstruction, which may include massively distended loops of bowel with absence of colonic gas. The presence of air in the cecum or terminal ileum can help to exclude intussusception in patients with a low clinical suspicion of the disease. Retrospective series out of Columbia Presbyterian. 129 pines, 27 of which had intus. If all three views had air in ascending colon, then 100% sense, NPV of 100% for RO intus. If two views had air in the ascending colon, then 96% sensitive and 98% NPV. The presence of air in the cecum on at least two views had high sensitivity for excluding intussusception in this patient population with a low clinical suspicion of disease, sensitivity 96%. Diagnosis: target sign, crescent sign. A target sign, consisting of two concentric radiolucent circles superimposed on the right kidney, represents peritoneal fat surrounding and within the intussusception. A soft tissue density projecting into the gas of the large bowel, representing the intussusception, is called the crescent sign. Diagnosis: the classic ultrasound image of intussusception is a bullseye or coiled spring lesion representing layers of the intestine within the intestine. The sensitivity and specificity of this technique approach 100% in the hands of an experienced ultrasonographer. An advantage of ultrasonography is that it can diagnose the rarely allele intussusception and identify the lead point of intussusception in approximately 2/3 of cases in which underlying pathology exists. Diagnosis: contrast or air enema is both diagnostic and therapeutic. Treatment: prior to reduction, the patient should be resuscitated and given antibiotic coverage. Non-operative reduction. Treatment: non-operative reduction. Surgery. Indications for surgery include flea aeroperitonitis. Treatment: reduction of intussusception is typically performed under fluoroscopic guidance, using either hydrostatic, contrast, or pneumatic, air, enema. Successful reduction is indicated by the free flow of contrast or air into the small bowel. Success rates of 85% to 95% are reported. Pneumatic technique. Air enemas reduce the intussusception more easily, and may be advantageous if perforation occurs. The technique begins with insertion of a Foley catheter into the rectum. Reflux of air into the terminal ileum and the disappearance of the mass at the ileocecal valve usually indicates reduction. A sphygmomanometer can be used to monitor colonic intraluminal pressure, typically not to exceed 120 mm Hg, to aid in reduction. If fluoroscopy is used, water-soluble contrast material can be instilled to confirm the reduction, or the air reduction can be repeated if the completeness of reduction is questioned. Risks and complications. Perforation of the bowel occurs in 1% or fewer patients. Risk factors for perforation include age younger than 6 months, long duration of symptoms, e.g., 3 days or longer, evidence of small bowel obstruction. The pneumatic reduction technique provides an advantage if perforation occurs, because air is generally less harmful than other contrast materials in the peritoneal cavity.